Hello, my name is Jennifer Lee Dick, and I'm with Psy.D Psychological Incorporated. And this is my colleague, Jocelyn Levitan. And let's see, I went to Fuller Graduate Seminary, and I did my residency at Children's Hospital Los Angeles, where I worked with children on the spectrum as well with trauma. Do I need to start over, or? No. Okay. And so there at CHLA, I work with children on the spectrum as well with some trauma. And my specialty area was working in our medication clinic, actually with Dr. Richard. And I'll let Jocelyn say a few words, too.
Height differential here, and we're switching on and off in our presentation. So this might be interesting, but please bear with us. So I am Jocelyn Levitan. I actually got my combined doctorate in clinical counseling and school psychology at University of California, Santa Barbara. And I came down to LA for my internship, which I did at Children's Institute. And I worked with a lot of kids who have experienced trauma with comorbid anxiety and depression. And right now I work with Jennifer at Psy.D Psychological, which is a group private practice in Sierra Madre, where we do a lot of different group therapy programs, individual therapy, family therapy, and comprehensive psycho-ed evals and assessments. And we are also trained to do the ADOS. So I will give it back to you, Jennifer.
Thank you.
I'll stay up here.
Okay. Okay. So as the slide states, we will be presenting on understanding and addressing anxiety and depression with children with autism. So a quick overview of what we will be discussing tonight is the criteria for the DSM-5 of Autism Spectrum Diagnostic, Anxiety and Depression. The DSM-5 came out about a year ago, so I'm not sure how familiar you guys are with the new DSM criteria, so we will briefly discuss that. The overlap between anxiety and depression, and autism with anxiety and depression, and then treatment interventions for anxiety and depression with autism, which can include individual, family, and group. So the DSM-5 criteria for autism, there have been a few changes, however, some of it has stayed the same. Am I too loud now? I'm good? Okay. So the first criteria is I'm too loud, okay. I am too loud, just let me know. So persistent deficits in social communication and social interaction across multiple contexts, such as deficits in social emotional regulation, so if they're able to kind of regulate their emotions, or do they have tantrum or anger outburst, the ability to communicate, are they nonverbal, are they verbal, and also the ability to develop and maintain relationships with their caregivers as well as peers. There's also restricted, repetitive patterns of behavior, and must be demonstrated at least 2 of the following areas. So are they easily perseverative? So do they constantly either say the same things over and over again, such as scripting? Do they constantly play with the same toy? And it can only be that special red truck. If you give them a blue truck, will they tantrum? As well as if they're feeling hypo or hyper-reactive to some sensory stimuli, such as their clothes. Do they not like to wear socks? Do their jeans feel scratchy? Or are they constantly seeking sensory input? And also, symptoms must be present in early development, typically between the ages 0 and 3. Symptoms must cause clinically significant impairment in social and occupational. And occupational doesn't mean are they able to work or do chores. It mainly means if they're able to have a variety of interests. So do they like to play with trains, with sand, with trucks, with blocks? So a variety, or is it only the same thing? And severity, this is kind of new with the DSM-5, is that they kind of characterize it into levels. And so level 1 is requiring support. And this is kind of what we think of as maybe higher functioning. So this is a child who is able to communicate their thoughts and desires. However, they're kind of rigid, and they might only want to talk about themselves or what they're really into, and they are not as interested in you. So this is like a one-sided conversation. And while they're playing with their peers, they might not have a lot of flexibility. For example, I was playing Connect 4 with one of my clients, and he didn't like the way that I was putting in my chips, and so he covered them, and which is very clever. It's good problem solving. However, if I were a peer at school, I might get really upset and not want to play with him anymore. And so this is a child who's able to play games and sit down and have an engagement, but there's still a significant level of rigidity. And then also with the level 1, transitions can be difficult. They might be able to transition, but it requires some support. Level 2, so there's requiring substantial support. So this is a child who is verbal, but might have some limited abilities in that area. Play-wise, they might engage in parallel play, so it looks like they're with a group of their friends. However, they're just mainly playing by themselves and not really interacting with a child next to them. And level 3 is requiring very substantial support. So this is a child who is nonverbal, is very rigid, is not aware socially. You can come and sit next to them and they won't even notice that you're there. There's no acknowledgement. So high versus low functioning, and this is a term that's not necessarily in the DSM-5. However, professionals and parents tend to describe their child as high or low functioning on the spectrum. And so the DSM-5 kind of is very confrontational, or not confrontational, but they got rid of Asperger's, and I know that caused a lot of upset parents and even upset teens and adults. But that's kind of more of how we think about the higher functioning, is that they have that, they're able to communicate. However, there's lack of social interest or social abilities. They're not able to pick up on some of the social cues. And then low functioning can kind of relate to maybe an intellectual disability, lack of language, and again, so this is all going on a spectrum from kind of low to high. The prevalence is 1 in 68 children, 1 in 42 boys, and 1 in 189 girls. So coexisting conditions with ASD, these are not in a particular order, but I do want to highlight that some children who are diagnosed with autism we also see them have a lot of symptoms of ADHD, and I think the research says over 70% of children have ADHD symptoms, and that's because they might seem distracted and they might also come across as impulsive. Another one that we see is oppositional defiant disorder, just because of their anger outbursts and their tantrums, difficulty following along. And they might have other mood disorders, Tourette's disorders, and attachment disorders, because there's the inability to kind of relate to others, and the sensory processing disorder. And today we're going to focus on anxiety and depression. That Jocelyn will review the criteria for.
How about this? Does this work? Problem solving. Great. Okay, so you guys all have this. Better? Okay. So you guys all have this in your handout. So I'm not going to go through all of the criteria here. I'm just going to point out a couple different things. So there's a lot of different anxiety disorders. I'm not going to talk about them all today. I'm going to cover a few that in particular impact kids on the spectrum. So generalized anxiety disorder, it's kind of what it sounds like it is. It's anxiety that's generalized to multiple different things or activities in a child or adult's life. And kids and adults find it pretty difficult to control the worry. For adults, it's associated with at least 3 of the following things listed up here. And interestingly, with children, they only require one of these. Social anxiety. So this is anxiety that particularly impacts social situations. So kids or adults feel a lot of worry or even fear when encountering any type of social situation where they feel like they might be scrutinized or judged by others. And in particular, they worry that they're going to be negatively judged by others. What happens in social anxiety a lot is that these individuals then start to avoid all situations, which creates this cycle where they're avoiding situations because they fear it, and then they're never gaining the information that actually maybe there isn't anything to fear, and then that just increases their anxiety to the point where then they're avoiding all social situations. Separation anxiety. This is anxiety and fear about being separated from an attachment figure, typically a caregiver. And this is distress, worry that this caregiver, this attachment figure is going to die or get an illness, or that they're going to be separated from them somehow. These kids might get fearful of going to school because they won't know where their caregiver is. Going to sleepovers at other kids' houses. Frequently they get nightmares about these things. And depression, I'm going to go over just two major categories here. So major depressive disorder is characterized by one of two things: a depressed mood, surprise, surprise, and a loss of interest or pleasure in things they typically enjoy. So with that, there is a host of different criteria that can come with that, and I'm going to talk about that in a second. So one of the things I want to highlight here with major depressive disorder, these symptoms have to be going on for at least 2 weeks, while with persistent depressive disorder, also called dysthymia from the DSM-4, are similar symptoms, but they have to occur for 2 years. So this is something that has persistent depression. In children, it only has to occur for 1 year. Okay. So all graduate students are taught this mnemonic device called Psy.D caps, and I really find this beneficial when I'm trying to look out for if a child or an adult might have depression. So I'm hoping it'll help you too. So S, sleep changes, so either having difficulty sleeping or sleeping way too much. I for loss of interest in activities. And these specifically are loss of interest in activities that they used to enjoy. G for guilt or sense of feeling worthlessness. E for energy or lack of energy, fatigue, lethargy. C for difficulty concentrating or paying attention. A for appetite, so either eating way too much or too little. Psychomotor disturbances, so this is movement that's really slowed down. And then some kids and adults also suffer from suicidality. Okay, so interestingly, or maybe this makes sense to other people, but anxiety and depression tend to co-occur, happen at the same time. And there's a lot of different hypotheses for why this happens. And furthermore, there's these 3 different pathways that a lot of the researchers and theorists and clinicians are talking about. So the first pathway, which is the most common, is people who have a diathesis for anxiety, so a predisposition to react to stress with anxiety and negative affectivity, and have thinking patterns that are really not that helpful for them. And so the pathway 1 says that the propensity for anxiety then leads to the onset of depression. So an example of this would be a child who has anxiety-driven social avoidance. So they're socially anxious. They start avoiding going in social situations, or when they are in social situations, they kind of act really weird and awkward, and then which increases their likelihood to be rejected by peers. As they're getting rejected by peers, they become more and more isolated, which then leads to loneliness or low self-esteem and sadness. Pathway 2, which is the most straightforward is someone who is prone to react to stress with both depression and anxiety, and they happen kind of at the same time or simultaneously. And then pathway 3 is the least common and actually the one that there's the least empirical support for right now, but it's someone who is prone to reacting to stress with depression. And the depression-related impairments actually become the source of anxiety. So one example here is a child who's depressed will start to withdraw socially, and because they're not getting the exposure to peers and interacting with peers, all of a sudden now they're lacking some social skills and don't really even know what to do or how to interact with peers, which then leads to them really fearing those interactions because they're scared they're just not going to know what to do. Another example of this might be someone with depression having a lot of trouble concentrating in school, and then starting to do pretty badly on tests, and as they keep doing badly on tests, then they start to fear being tested because they're worried they're going to fail. Okay, some interesting stats. So 25 to 50% of youth with depression will also meet criteria for an anxiety disorder sometime in their life, whereas only 10 to 15% of youth with anxiety will also meet the criteria for depression. So why is there an imbalance here? So there's a couple of hypotheses. One is that kids with anxiety, the symptoms of depression they have might be subthreshold, so they might be having symptoms of depression, but they might not meet the criteria for a depressive disorder. The heterogeneity of anxiety disorders, so there's a ton of different anxiety disorders out there, and they vary in their predictability of depression, whereas social anxiety and generalized anxiety are actually the most predictive of depression in the future. The developmental onset, so anxiety, typically the onset is earlier in childhood than is depression, which tends to be more into adolescence. And most of the research out there has actually focused on anxiety as the predictor of depression and not the other way around. What accounts for the comorbidity? So some of it, which we might have been seeing already, is there's just symptom overlap. A lot of the symptoms of anxiety are also listed as symptoms of depression. For instance, with generalized anxiety and major depression, fatigue, a sleep disturbance, concentration difficulties, irritability in children, these are all symptoms of both. There's also similar information processing biases. So people with anxiety and depression both have a tendency towards negative thinking or maladaptive thinking, to the point where when something happens, they're going to catastrophize, think of the worst possible outcome. They might have a tendency to ruminate, either ruminating on what they did wrong or ruminating about all the bad things in their lives, and both have a lot of worry about the future. In particular, for social interactions, they have maladaptive interpretations of these. Specifically, they have a tendency when a social interaction doesn't go well, they have a tendency to see it as their fault, that something internal within them, that this is stable, that this isn't something that they can change, and also they have a global attribution. So not only is it within inside me and I can't change it, but this is going to happen every time I have a social interaction. These are not going to, these youth aren't going to bode well when it comes to social interactions if these are their tendencies.
Thank you. So autism and anxiety. 40% of children with autism had at least one comorbid anxiety diagnosis. And with higher functioning, so kids who are able to communicate their thoughts and feelings, they're also aware of their peer interactions. So they will report more anxiety because they're aware that the kid just walked away from them or name calling that's happening. And so they will have some more anxiety in social situations. And then the lower functioning children, they still might feel some of that anxiety, like they might notice that the children over there are playing. However, they're just unable to kind of communicate it in a way that we can diagnose as anxiety. So it's really important to kind of keep aware of the symptoms. So like kind of what Jocelyn so greatly kind of gave an overview of, you know, are they sleeping? Are they afraid to leave the house, or in social situations, are they clinging to your leg and just crying without a reason? And similarly with autism and depression, 30% of adolescents and adults with autism have met criteria for at least one episode of major depressive disorder. 10% of children met full DSM-4 TR criteria for major depressive disorder, and 14% reported significant symptoms, however, it wasn't diagnosable. And so symptoms of depression are occurring. There needs to be more research in this field, partly because the symptoms of autism and depression, it might be exacerbated by the autism symptoms, such as social withdrawal, not being able to communicate, and so they're not able to kind of report their depressive feelings. So once again, it's important to kind of observe and take note of changes, especially as parents, because you guys are the experts of your children, and so you know, like, hey, are they waking up more in the night? Are they crying more? Are they no longer interested in that favorite red truck, and now they just want to sit in the corner by themselves? Or, you know, they used to be able to sit with other kids, and now they just want to be alone completely. Let's see. So that's why it's important to also seek professional help to kind of see, you know, hey, my kid no longer wants to do these things, and kind of talk with a professional to kind of figure out if it's anxiety and depression and what interventions to use. Autism and family dynamics, and so there's a lot of research that's analyzed the family dynamics, because you guys, or parents, have so much going on and so many hats that you're wearing. And so there's financial and emotional distress. And financial, let's say both parents are capable to work, however one has to stay home because they have to shuttle and go back and forth to so many different therapies, or they have therapists coming to the house, so they need to be available. And there's emotional distress because some of these children have anger outbursts and behavioral issues that's really complicated, and so it kind of wears down on parents. Parents of children with autism have increased depression, anxiety, stress, and exhaustion than parents who have children with Down syndrome, intellectual disorder, and conduct disorder. And this just goes to show that parents with autism, they're in a special category, and they have so much kind of going on. And also, because of so much going on, there's less family cohesion. There tends to be more marital distress, and also the attachment with their other siblings, or other children in the home. And research is really interested in looking at the maternal stress, because the moms tend to be home and kind of take the children to the therapies more so than the dads, because they're working, even though there are some dads who are very active in their children's therapies. So mothers of children with autism experience higher levels of depression, psychological stress, and difficulty adjusting to their child's challenges than do mothers who have a child with intellectual disabilities, spina bifida, or Down syndrome. And so, interesting, the research suggests that there's a correlation between the mother's stress and reported behavior problems in the child with autism and other children in the home. And so, one influences the other in the system. And so it's great to kind of help address the whole family system when we're thinking about interventions. And so there's relational-based treatment. So progress in treatment is made through developing intimate relationships. And the focus is creating an intentionality in relationships. So being able to have the back and forth and helping the child recognize that you as a parent has thoughts and feelings, and for them as a child to feel understood. And the goal is to generalize the progress across settings so that the child, teen, and even adult becomes more holistic and developmentally functional individual who can regulate, relate, and communicate. And so part of a relational intervention that is commonly used is called floor time. And those are short periods of time throughout the given day where you spend child-led play. And so you're interacting with the child in a way that's helping them build up through the milestones. And the milestones, there's 6 different levels, and level 1 is regulation. So, for example, if the child is really hyperactive and loves to run around and never sits still, and so an intervention to help regulate them is to kind of join where they are, and then help them to calm down a little bit. So they might need to take deep breaths. They might need to be squeezed with a pillow. I kind of like to do sandwiches, so put a pillow on the ground, and the child is kind of like the meat sort of way, and put another pillow as the bun, and just to kind of give them that sensory input. And so that way their body is in a place where they can regulate and also engage. And so engage, are they able to look at you, and when you laugh, do they laugh, and you guys are able to laugh together. And so we're really looking for that engagement that is first needed for them to be regulated. And once you're able to have that engagement, then we work on the two-way communication. And I kind of think of that as like a tennis match. So if I say something, is the child able to respond, and then I respond to what they're saying, and so there's this back and forth going. And then problem solving. So are they able to kind of think of solutions to a problem? So let's say they're playing with a castle, and a princess is stuck and the castle's on fire. Are they able to kind of think of solutions like, oh, let's get a ladder, let's call the fire department, in the play kind of modality? And then symbolic ideation is to get them to actually become that character. So it's not necessarily narration, but they're being that prince or princess in the castle, and they're able to then kind of think about how another person or another character might feel, and that kind of helps with them to be able to understand how you're feeling and how they're feeling outside of that play. And the last level is emotional thinking. So are they able to recognize when they're feeling sad, or when they're feeling happy or frustrated? And then are they able to then work on solutions to kind of help calm them down? Are they able to go to their parent and say, hey mom, I'm really sad right now because my brother just ate my cookie and I'm really mad. And so they're able to share their emotion and then together problem solve. And all of this is all these levels are achieved through play. And this is more of a relational type base and kind of going with the flow. There's not necessarily an agenda except for follow their play and to kind of help stretch them. And each time to kind of figure out how to stretch them more and more. That interventions continue. So marital therapy, and part of that is to help the parents kind of be on the same page and to kind of talk about their struggles. And we all come from different backgrounds and different families, and parents come with their ideas on how it's supposed to be, and it might be different from how their husband or wife was raised. And so coming to really get together jointly and talking about parenting styles and kind of how to approach parenting together. And the research has actually shown when parents are able to co-parent together and they're on the same page, that actually increases the family cohesion and the stress, not only with the child, but also personally. And individual therapy, so learning strategies to kind of cope with not only with the behaviors in your child, but also what brings up your child's behaviors, what brings up in yourself. And for example, I was in session the other day with a mom and a child, and the child was having a tantrum, and I've been working with this mom to kind of learn to kind of ride the wave, like to kind of let it go. And sometimes the kids are great at getting what they want, and sometimes if we have that back and forth with them when they're in a tantrum, it only kind of gives some fuel to their fire, and they kind of get more out of control. And so we're working on keeping the mom calm. And so mom stayed calm, and she kind of just rode the wave, and I gave her lots of praise because that's what we've been working on, and she was able to do it. And she's like, wow, that's the first time I received a compliment in years. And so I just want to say, like, you guys are doing a great job, and it's really hard. And even in therapy, to have someone to tell you that and to point out yes, these are the tools in your toolbox, and you're doing a great job, and let's work together to add some more. Because, like I said, you guys are the experts of your kids, and you know what works, and to kind of put your minds together to kind of even help your child to kind of grow and develop. And then Jocelyn is going to talk about some other strategies.
So I'm going to talk a little bit about cognitive behavioral therapy. This is a type of therapy that there is a ton of research on, particularly because it's very structured. So it's pretty easy to do research on, more so than kind of a relational therapy like play therapy, which I think is equally as good, but it's just harder to research. So anyway, cognitive behavioral therapy has been shown to be a great intervention for both anxiety and depression. The research shows it's really good for anxiety and depression that's mild to moderate with more severe depression. The problem is that then that's an individual who maybe doesn't even have enough energy to participate in therapy, has a lot of fatigue. And so typically you would want to get some med management going on too, so at least the meds will help them get to a point where they're actually motivated to participate and have the energy to do so. So the focus of CBT is on the relationship between thoughts, feelings, and behaviors. So we talked about how in both anxiety and depression, there's a lot of maladaptive thinking going on. So it's about learning how your thoughts actually impact your feelings. And by changing your thoughts and making them more realistic and positive, you can actually change the way you feel and consequently how you act in the world. With the thoughts, feelings, and behaviors connection, you're also teaching a lot of coping strategies. So a bunch of the things that they have in common is starting out with some psychoeducation. What is anxiety? What is depression? What does it look like in our bodies? How do we know when we're experiencing it? Relaxation strategies, so that'll be mindfulness strategies and calming strategies. Identifying emotions. It's hard to be able to express how you're feeling if you have no idea what you're feeling, so learning how to identify those. Cognitive restructuring, that's talking about changing our thought patterns. And then exposures, kind of figuring out what it is that we're having difficulty doing. And starting with the ones that are just a little bit difficult and working our way up to things that are much more difficult. And then scheduling pleasant activities in our day. A lot of the time, the big impact of depression is we are not engaging in activities we used to enjoy and not getting that opportunity to even have those pleasant experiences. So there has been a lot of research lately. A lot of it's been done at UCLA, actually, right nearby, of using CBT with children on the spectrum, particularly with more high-functioning children, because the CBT is pretty verbally based and can be a little bit abstract. There just hasn't been enough done with lower-functioning kids on the spectrum yet. So they do incorporate some modifications for kids on the spectrum with CBT, so they incorporate a lot more concrete visuals. So these will be feelings thermometers, lots of feeling faces. They might spend more time on how to identify emotions. Try and incorporate specific interests of the child into therapy to make them more likely to want to engage. Doing a hierarchy based on difficulties that are specific to kids on the spectrum. So this might include social skills training pieces. It might include adaptive functioning and daily living skills. If a child has very restrictive interests or obsessions and compulsions, you might include that as well. And then a lot of more parent involvement here, because we need the parents to be practicing these skills at home. A lot of the times parents are surprised when I ask them to be involved in the therapy sessions. And you know, with a lot of the teens, I'll do one-on-one with that teen, but for any child who wants their mom in there or their dad in there, I want them in there more, because guess who's doing these skills with them at home? Not me. They're the ones that are with them all the time, so they need to know these skills too. And just like Jennifer had said, a lot of these skills actually really help them. I've had moms come in and go like, oh, that deep breathing really works. And the more they can get excited about that, the kids will get excited about it. Okay, groups and social skills groups. I think groups are so awesome. I can't talk enough about these. I run quite a few of them at Synergy. They have so many benefits that you just can't get in individual therapy. If you just, I'm pretty young, but I'm so not hip with the stuff that's going on today in these kids' lives. So it's so amazing to me when they can start talking about some anime or some video game, and they're talking about something, and in my mind I'm like, oh, this might be one of like their restricted interests. No one knows about this, and I'm like looking at them blankly, and I look around the room, and everyone's nodding along, and like they know exactly what this child is talking about. So it's just an opportunity to be with people who are like them, who are experiencing the same difficulties as them, can be really healing. Just even being in the room and knowing, hey, everyone else here is experiencing the same thing as me. It's an opportunity to practice skills in vivo in the room. I can role play with kids, and I can role play how another kid might react, but that's nothing compared to the kid actually reacting in the moment. Reduces stigma and isolation, I talked about that. The opportunity for altruism and to use their experiences and their difficulties and the things they've learned how to cope with to help others in the room is a really powerful experience, and it promotes a sense of self-mastery and self-efficacy. Like, okay, like I really have learned something from what I've been through, and I can help another person through that. That's pretty cool. Increases their ability to trust others. A lot of kids on the spectrum experience a lot of peer victimization, so it's a nice opportunity to be able to re-experience trust in a safe place, in a safe setting. And decreasing social anxiety. So one thing that I find is a lot of kids who come to a social skills group have been to many social skills groups in the past. And they're telling me that, I know the skills, I have the skills, I've been to so many of these, I'm just scared to do it. And so I think often social skills groups are just thrown at kids on the spectrum saying this is what they need, social skills group, when actually they have the social skills at this point, they need to overcome the anxiety around it. So I always incorporate a lot of anxiety management techniques in my group. I also have an anxiety group as well. Groups for teens in particular, this is a very angsty time, a time where kids, the peer relationships become so much more important, and as kids get older, and kids on the spectrum get older, they start to have a greater awareness of their differentness sometimes, and of their difficulties. And for teens too, this is also a time where they're much more likely to listen to their friend than they are to an adult, because adults just don't get it, and their friends do. So yeah, I can't talk enough about groups. We have a ton of groups from kindergarten, actually preschool, all the way up through early adulthood. So it's just incredible, the transformations I've seen in these groups. Okay, now we're going to hear from Dr. Pritchard.
Can you hear me? I just got all suited up by our friend in the back. Can you hear me okay? I'm also very loud. I really don't even need a microphone. Well, I'm going to introduce myself. I'll tell you that I actually grew up around the corner from here. I've lived in Pasadena all my life, right next to the Rose Bowl. I literally walk this area all the time. My kids went to preschool in this setting before it was this place. It was Pacific Oaks Children's School. I grew up in a family with 4 individuals, a mother, a father, and a brother who happens to have autism. He was diagnosed back in the late 50s, even before I was born, before there was a regional center, before there were specialized programs. So I grew up, actually one of my earliest memories in my house, which was actually a very happy and productive house. I know these conversations can sometimes sound sort of like downers, but anxiety and depression are really part of the, well, I'll say anxiety and sadness in life are part of the human experience, no matter what we experience, okay? This room just happens to have people who've experienced autism. There are other people who are experiencing cancer, heart disease, children who've run away, poverty. I mean, none of us really gets scot-free from some of life's challenges. So this subject is a little serious, but I like to always think of the brighter, the positive, the good that comes out of going through challenges. So I'll tell you a little bit about my experience. When I was very young, one of the things I remember, and this is why the title of my presentation, oh, that's not the beginning of it, is about families and families dealing with depression, anxiety, living with autism. Because it's not, first of all, anytime there's anybody in a family who's anxious, anytime there's anybody in a family who's depressed or sad, the whole family has a problem with anxiety and depression because the family is a system. I remember being very young, before I was ever told what was wrong with my brother, seeing my mother on her knees. My brother was at her height, so I must have really been little because I'm about 3 years younger than him. He was probably 6 or 7. And she wasn't shaking him, but she had him by the shoulders in this very desperate way, saying, "You will talk, you will talk, you will speak to me, please just speak." It was like this desperate, I think she had just been very frustrated that day. It wasn't that she was always that way, but something had happened. But I knew as a younger child that I was not supposed to be part of that. I stayed kind of hidden, even though I had a very loving mother, open person who would have embraced me if I'd come toward her. But I knew, I could tell this was like a moment that I wasn't supposed to be part of. So your whole family is experiencing this experience, as if you don't already know that. But that's something I just want you to know that I'm very, very aware of. A little bit about my educational background. I'm a developmental behavioral pediatrician and a general pediatrician. I, as I said, grew up here, went to Westridge School right down the street over here. How many of you are from this area? Sort of more Glendale, Burbank, but I went to Westridge School, graduated from there, and then I went to Stanford University, and then I went to UCSF, UC San Francisco Medical School. Came back here and did my residency at Children's Hospital, and had 4 children from the time I was an intern to, 13 years ago. So I have a 25-year-old, a 22-year-old, a 20-year-old, and a 13-year-old. Then went into private practice in general pediatrics with my father, who was a pediatrician around here also. Left there. People started noticing for some reason that I had an interest in development. I always have. My mother was a Head Start state preschool director, and my aunt was the principal of a school around here. So our whole family was always around development and children. And so I started working at the Regional Center as a medical consultant there. And I'm still there at Lanterman Regional Center. I've been there for about 15 years now. I also became board certified in developmental behavioral pediatrics. And if you want to know what that really means and what that is, I say it's sort of like a combination of a general pediatrician, a neurologist, a geneticist, a psychiatrist, and a therapist, right? We used to work together, and people kind of go, like my husband, I'm trying to find a new space, and he's like, what exactly? Because I say, well, I want to make this like a playroom, I'm going to have toys, and we've been married for quite a while. He's like, what do you do? Like he asked me, like, I'm like, I like to play. He's like, oh, okay, I thought you were, So anyway, I've been places. I've been an assistant professor of pediatrics both at USC Children's Hospital and now at UCLA. I have a small private practice here in Pasadena where I see kids, a lot of kids on the spectrum, a lot of kids with ADHD. As you all know, a lot of these things are comorbidities where we have kids on the spectrum with the other symptoms. I do a lot of medication management, which I'm going to talk a little bit about today. And then I also have been part of an autism assessment team, an interdisciplinary team, and I know a lot of you know Dr. Sonia Aller, or Sonia, who's part of this organization, and she and I have worked together on a team for about 3 years. So since we shared our presentations, I know they've gone through the diagnostic criteria and what it means. I'm sort of not going to do that. I want to talk, no, I'm not a techie. Okay, so I'm going to talk a little bit. I want you to put on your thinking, not just for your child who's on the spectrum, but for yourselves and for your family, okay? So I think this is one thing, everybody's talking about, marital stuff or relationships. When my parents had their 50th wedding anniversary party that I threw for them, all my mother could keep saying was that we made it and we have an autistic child. That was like one sentence. It wasn't, we made it. Oh, and look at all the other things we've gone through. It was that was like one sentence. And now I think it's like 64 years. So think of everybody. Think of the siblings. Think of yourselves. Think of the community you live in, your neighbors, when I talk about these subjects, and then we'll kind of bring it all back around. So anxiety in general. How many people in here have felt anxiety? I mean, yeah, I'm known for anxiety. I call a lot of this stuff apple tree stuff. Do you guys a lot of us are sort of genetically predispositioned to be worriers, sort of the way you were thinking, what you're talking about our thinking, how are we sort of, and it's not just what we're genetically inclined to do, but it's also how we're raised. So if we're raised by parents who are a little bit more on the anxious, like my daughter, we went to camp, she went to Catalina Island Camp, and I took her to drop her off, and her counselor was there, and my daughter says, "Hi, this is my mom, Leslie Richard, who's afraid I'm going to be eaten by a great white shark." And that is really how I am. I try not to do that. She'll call me on the subway. She lives in New York. I'm like, "Why are you talking to me on the phone? Are you on the subway?" She's like, "Yes, Mom." I'm like, "Get off the phone. Pay attention." She's like, "Stop watching Law and Order," But I mean, I'm always like, what's the worst case scenario? What could happen? What could happen? So anxiety, okay? But anxiety, this is the difference to me in anxiety and stress. Anxiety is a normal reaction to real or perceived threat, okay? I think the important word here is not just the real part, but the perceived part. So a lot of times when we feel anxious, it's not about anything that's reasonable, like me being afraid of a great white shark. My husband mountain bikes, and I say, "Watch out for the mountain lions." I mean, I can't help it. But so it's these perceived threats. And the time when we worry about it becoming really a clinical issue is when this excessive fear or worry interferes with normal daily functioning. And that does happen to some of us. We have everything on the spectrum of anxiety, from feeling a little nervous from a test or feeling excited when you're getting a new job, or to the point where you can't get out of bed because you're so afraid that you're going to get hit by a car that day, a totally unreasonable thing, or you have a funny feeling that there's going to be an earthquake. So when anxiety becomes frequent, so you're frequently having anxiety, it's severe and persistent, that's when you have a clinical problem. And you all know about our fight or flight response. I mean, if we didn't have anxiety in our lives, we wouldn't survive. We have to have a little bit of that fear, our heart racing, our stomach getting a little nervous, all those somatic things, so we can be ready to fight or flight if we have to. So we're wired this way for a reason, but sometimes it becomes an excessive problem, and that's when we need to recognize it as a clinical problem. So these two already talked about anxiety disorders, but in general, there are warning signs for anxiety disorders. Now remember, you're thinking siblings, you're thinking yourselves, and you're thinking your child on the spectrum, but we're going to talk more specifically about that child a little bit later. So warning signs that there really may be a disorder going on. One is persistent fear or worries. So like I said, we all worry and have fears, but whether they're persistent. Excessive self-consciousness or shyness. Anxious people, it's like, am I okay? Do I look all right? Is this okay? Do you think I did it right? That self-doubt. We talk about OCD being a very severe form. It's really not thought to be an anxiety disorder, but it's kind of in that spectrum of anxiety. And a lot of, I was reading something the other day that OCD is really the disease of doubt. Well, anxiety is a few steps before that, but it's basically a problem of doubt. What's going to happen, not knowing what's going to, now other people would say, well, it's a lack of faith, but there's doubt there, self-consciousness and doubt. You'll find people who are very anxious, sometimes being sort of overly sensitive. A lot of physical complaints. We see this with kids a lot. Tummy aches before school, headaches when there's going to be a big test, not wanting to, vomiting before a big sporting event. So physical complaints, our body is wired, the whole mind-body thing. And that's why a lot of the things we do, I heard you talking about exercise and breathing, a lot of the things that we actually can do to help relieve anxiety really are things that physiologically change our responses. So if you think about the sympathetic and the parasympathetic nervous systems, that fight or flight thing, they're all related to different nerves and neurotransmitters. And I talked to a psychiatrist a while ago, actually saw a presentation where she said with her anxious adolescents who call her, I'm feeling so nervous, she says, just take 5 deep breaths. Now we all know, we've all heard about take a deep breath forever, but really physiologically, and I'd never thought about this way, because of the vagus nerve, which is all up in this area from the brain, you cannot have a rapid heart rate when you stimulate the vagus nerve. It naturally slows the vagus nerve. So deep breaths at least will stop those physiologic reactions of anxiety. And I hadn't really thought about that way, even though probably in medical school I should have put those connections together somehow, but I really didn't. So the deep breath thing really does work, at least to get a person out of that sort of sense of actual threat that's physiologic. Sleep difficulties we see. Now what's interesting with anxiety and depression, with anxious individuals we often see difficulty falling asleep. With depression we often see people having difficulty staying asleep. So those are kind of different things, questions I would ask, or a good therapist or psychiatrist would ask to sort of differentiate between the two. Avoidant behavior we talked about because there are so many different types of anxiety disorders. And then an excessive need for reassurance that often is ineffective. Have you guys had people like that in your lives or yourselves? No, I mean, I talk to myself all the time and I'll tell myself, no need to worry about this. No, my son's a little anxious. I'll tell, I always try to do, did you guys ever watch Dragnet? Remember Dragnet? Ma'am, just the facts. That's what I tell myself when I start getting anxious. Like I say, okay, what are the facts here? What are the facts? Because the excessive need for reassurance is often when a person is not looking at the facts. They need reassurance that something isn't going to happen or hasn't happened, that they aren't taking into account what really is the reality of the situation. Other warning signs of anxiety disorders are poor school performance. A lot of kids will, come in about ADHD or other things, poor attention, and it looks like there's really a lot of anxiety going on. This is a big problem I think in pediatrics, where a lot of families, not necessarily whether the child's on the spectrum or not, but a child will have anxiety and a lot of inattention, and they'll come to the general pediatrician and they automatically assume that it's ADHD, where really the child is distracted because they're preoccupied. There's often a preoccupation when people are anxious, especially if it's severe. They're preoccupied with whatever that anxiety is. I don't know if you all were around here, all of us were here, I suppose, during September 11th. But, there was the national preoccupation with our safety. And that, we were probably a disordered nation for a little while, if you looked at the criteria. But we can get preoccupied where we have trouble functioning, we have trouble paying attention and focusing because we're fearful. And then we have temper outbursts. I don't know if there are times where you feel like everybody's pushing you. Come on, we gotta go, hurry up. Where's this, where's that, your boss, your kids, and temper outbursts. And that's, often what we'll see with kids on the spectrum.